My name is Mario Cascio. I'm a person who has been living with HIV for over 40 years, and I am currently the Program Chair of Quality of Life for the European AIDS Treatment Group. I'm also the founding member of NPS Italia, which is the first network of people living with HIV in Italy.
My name is Marta Buffito. I'm a consultant physician at Chelsea Westminster Hospital in London and a professor of practice at Imperial College London. I have been working within the fields of infectious diseases and HIV medicine for approximately 25 years, and I'm the clinical director of the Department of HIV, Sexual Health, Gender Health and Dermatology at Chelsea Westminster Hospital.
My name is Daniel Simões. I am based in Lisbon, Portugal, and besides being an EATG member for the last roughly 15 years, I've been working in community-based organizations in the field of HIV, viral hepatitis, sexually transmitted infections. I am also a licensed psychologist, and I have a PhD in global public health. So I've worked in the past in mental health in other communities, but I have previous connections to mental health.
Okay, mental health is seen as a state of well-being which enables you to do the things that you treasure most in life and coping with the difficulties in living. So I would say it's about enjoying life, at the same time coping with its stresses and difficulties.
Mental health is generally seen as being in a state where you can face life, let's say, properly. So you can, even when there's adversity, you have the capacity and the tools within yourself to respond to that adversity and to continue with your life in as much of a positive way as possible. It doesn't mean that you're always happy, that you're always in a very good mood, but it means that you have the inner strength to face difficulties that life throws at us every day. It also means that you have the capacity to enact your life so that you can work, you can learn, you can do things that you like, that you love, that make you feel useful and make you feel good.
Well, mental health and wellness are indeed very much related with each other. I work in a clinic where mental health services and HIV services are well integrated, and we do our absolute best to follow guidelines like the EACS guidelines or the BIVA standards that promote mental health, that promote addressing mental health and well-being for people living with HIV. And this is really important because there are still data in the literature that show that people living with HIV are more likely to experience anxiety and depression, and this has a negative impact on their quality of life. Again, it gives us the responsibility, healthcare providers, to address their depression and the anxiety and to work with psychologists, psychiatrists, and other services like peer support, for example, that can help people living with HIV address their mental health concerns.
Getting an HIV diagnosis, either it was 30 years ago or 20 years ago or just recently, has always been a source of psychological distress. And if you add to that the fact that HIV continues to be one of the most stigmatized diseases across the world, and let's not forget that many people living with HIV also belong to groups which are already highly stigmatized by society, such as sex workers, migrant populations, LGBT community, and so on, which gives an additional layer of additional stigma an additional burden, psychological burden on people.
If we look back to the early days of the epidemic and even to a lot of the communication that was done around HIV was a death sentence. And so there was a huge weight around the infection. And that weight was not only in terms of physical health, but it was a very, very heavy burden in terms of mental health. I know people who were infected in the 80s and the early 90s, and they're fortunately still alive. But it was a very, very big burden to carry at the time because you were pretty much told that you were going to die in a matter of more or less months. So there wasn't really much hope. While HIV and the treatment of HIV has evolved dramatically over the last decades, unfortunately, there is still a bit of this image in the heads of many people, and due to lack of information, to misconceptions, etc., for many people, both living and not living with HIV, it is still a very, very heavy burden to be diagnosed with HIV. And for people who live with HIV, in many situations of their lives, it's a very, very heavy burden, both personally and with the experiences that they have from others.
So stigma is a phenomenon that we still observe in healthcare environments, unfortunately. And I think that the main reason for stigma is ignorance, is lack of knowledge around a certain circumstance. Of course, it is associated to discrimination, but very frequently it is the results of people not knowing, not understanding. And we do still see quite a lot of stigma in, again, healthcare environments.
But stigma continues to be out there and continues to impact the daily lives of people living with HIV. But I must also say that it has not always been fully acknowledged by our healthcare providers. And because stigma may not be the only driver of depression, but it is indeed one of the pathways to poor quality of life and poor quality of psychological well-being. So loneliness, social isolation, and depression are becoming part of the lives of many older people today living with HIV.
People living with HIV face multiple kinds of stigma, and stigma is on its own a very complex phenomena. And I think we have to divide stigma and discrimination. So stigma relates to what people think, and discrimination relates to what people do, so to the actions. And people living with HIV face both. And there is a part that is internal stigma, so the own thoughts that people living with HIV have about their own infection, their own behaviors. But there's a level that is exterior, so this level of discrimination and stigma from others is still omnipresent in society. There's a set of groups of communities that are most affected by HIV. And these generally are also groups of people or communities that either have behaviors or that have certain characteristics that are not very well seen by members of the general population.
Coping with the psychological distress has been part of the journey of many people living with HIV. And as a person living with HIV, it has always been part of my journey as well. I think that one of the most important things that people living with HIV should consider when coming to terms with the diagnosis of HIV is that of seeking help when necessary.
In short, what this means is that we have a very unfair society. And this has consequences for the well-being of people and for their mental health. Because if you are mistreated, if someone doesn't treat you in the same way that they would treat someone else, this will have an effect on you, a negative effect on you. Education, access to health, work, employment, housing, it exists everywhere. Society in itself is unequal and treats people unequally. So one of the things that is absolutely crucial is that we bridge this gap and we try and make sure that we start treating people as people, regardless of what they do or how they behave.
In the early days, stigma was so strong that sometimes people were even afraid just to sit next to you. Well, a lot of things have changed over these last 40 years, but stigma is still out there. There are still many misbeliefs and poor knowledge about HIV in general and modes of transmission. And still today, people are experiencing things such as rejections by partners, potential partners, or even, let's say, being treated differently, or sometimes even not being able to access healthcare services.
Stigma-free HIV care, and in terms of mental health care, there are multiple barriers. We can go straight into the lack of financial resources on the one hand, and in many settings, the lack of human resources, but also in some cases, the lack of models. Integrated care models are unfortunately still not the reality in the majority of Europe and the world. We have well-structured, for the most part, HIV services, but they are designed to treat an illness. And there should be a shift in the way that we look at services, and we should be trying to develop services that care for the person and not for the illness. So we should be trying to work preventively and not just to react, to respond. Obviously, when we're talking about people living with HIV, we're talking about, often in many scenarios, people who are in very difficult social and economic situations. Your probability of not being well, generally speaking, will be higher than someone who lived, let's say, an eventful or more peaceful life, who never experienced discrimination, who is in a comfortable social, economical, financial situation.
But I believe that self-stigma is the form of stigma which is the one that mostly impacts the lives of people living with HIV. Self-stigma is when you have negative feelings about yourself, feelings such as shame, guilt, or low self-esteem. Self-stigma is, of course, rooted in societal stigma.
We know that people who have an undetectable viral load don't pass HIV on. U equals U, undetectable equal untransmittable. But this is very much known within the HIV community. And I think we need to work harder, especially within healthcare systems, to ensure that everybody understands that U is equal U. We still observe some negative experience of people living with HIV within healthcare.
Unlike the earlier days, today we have a new tool, the U equals U message, which has the potential of really changing the lives of people living with HIV. It has, in my case, for example, when I learned of U equals U, it took me quite a while to understand and to translate it into my daily behaviors. Because I was, I understood there was a great distress in trying to hide, my pills or my toothbrushes, my razor blades, and so on. So when I finally managed to get this message inside of myself, inside my brain, my whatever it was a great relief. It was actually a big change in my life. And I think this could be of great help to people living with HIV. So people living with HIV have always had the feeling of being denied things which are very important in the lives of people in general, like having children or having a fulfilling sexual life. So I think the U equals U message is something can radically change the lives of people.
There is an urgent need to raise awareness, both at the level of infectious diseases, so HIV, viral hepatitis, TB, that have gone a long way since the beginning of the epidemics. Particularly HIV has drastically changed. And the majority of people have no idea. And for a lot of people, HIV is exactly the same thing today as it was in the 80s and 90s. People don't know that if you have undetectable viral load, you cannot transmit the infection. Sometimes not even people living with HIV are properly given this information. But there's a similar problem for mental health, because mental health remains the poor relative of physical health. Mental health continues to be widely overlooked by our medical systems, by our health systems in general, and implementation of mental health services overall in Europe is very low.
You may see that a woman with children who is living with HIV and has an undetectable viral load is still listed at the end of a surgical list. because she has HIV, and if she asked to please be seen earlier because she needs to pick up her children from school, she's told that's not possible because she has HIV. And that is not true. This is very old practice that doesn't need to be implemented any longer, because the fact that she's living with HIV with an undetectable viral load is well known that the HIV is not passed on. She can be at any place in the list. Healthcare professionals should be aware that undetectable means untransmittable, and we should support her to have the surgery at the time she needs to have it, like everybody else. And these circumstances cause stress, anxiety, depression, and are the results of a stigma, which is the results of lack of knowledge. There are people living with HIV that go to their GP to start a medication for a potential comorbidity, and they're told that it's better if they don't start any medication because they're on antiretrovirals. So again, it's about knowledge about drug-drug interactions, which are much less likely to occur nowadays with newer combinations.
So in my case, for example, having been in the past a drug user and having also been in prison, this has been an additional burden for me. Actually, I must say this, in some moments of my life, this has been even more strong than the HIV-related stigma.
So committing to a stigma-free healthcare is definitely a challenge, but I believe it's possible via communication, teaching and training our colleagues, of course inside the HIV department, but also outside. We know that people living with HIV are exposed to many other specialties, to general practice. So really try to share our understanding and knowledge of HIV, of U equals U, with our colleague outside the HIV field.
Equity is defined by providing different responses to people with different needs. So we need to build services that are equitable. If a person only needs to go pick up their medication every 6 months, that's perfect. But we have a lot of people who have additional needs, and mental health is one of them. And we have already a huge stigma around mental health, specifically in society at large. And that stigma also needs to be tackled.
So to effectively address stigma within HIV care and in mental health services, it is important that healthcare professionals understand the connection between physical and mental health. They must have a better understanding of the impact that stigma has on the psychological and physical well-being of people. And we also need that people living with HIV have a better understanding of this mechanism as well.
But also, very importantly, I think we have the responsibility of listening to people living with HIV, of different groups of people living with HIV, and design services based on their needs.
When we're talking about developing integrated services, we need to think that these services will not be the same for everyone. And we probably need to integrate a lot of different responses, so we need to be in contact with a lot of different specialties, a lot of different services, to be able to refer people, even if we cannot provide them ourselves, that we can link people into other professionals and other services according to their needs.
There is a piece of work that we're presenting here at the EACTS conference that we have performed in collaboration with the Sophia Forum. Sophie Strachan is the CEO of the Sophia Forum, and she also works with me at Chelsea Westminster Hospital in London. And we have interviewed Black African women and Black Caribbean women and asked them about their experience throughout the COVID-19 pandemic, because they're living with HIV, and how they found access to services, and also about the forced disclosure of HIV that some of them have experienced. And that piece of work, that experience, increased our understanding of how important it is to again listen to people and design services for their needs. Even just asking the right question when you see someone in the clinic, and again, listening and try to address their needs.
One of the things that I think would be essential in terms of solutions is to have differentiated models of care. You would have different responses according to the needs of the person. That can go from very, very simple responses that do not require very highly trained mental health professionals, like self-help groups, peer support, etc. And then you can scale along the model until very highly differentiated care for people with more serious mental health issues or even mental health disturbances or mental health illnesses. So to long-term psychotherapy and psychiatric support.
There are data in the literature showing, for example, that Black women with HIV are not referred to mental health services as much as other group of people living with HIV. This is something we need to address. This is a gap that needs to be filled, because we did discuss the importance of addressing mental health concerns in people living with HIV to decrease internalized stigma, anxiety, and depression. So we have the responsibility to actually do that.
In many European countries, there are laws which protect the rights of people living with HIV, but in many others they don't. So I think in those countries where such laws are lacking, I think we have to advocate for improving these laws.
Ideally, this would also lead us into a better communication and further integration between formal healthcare services and non-clinical health services or community services, let's say. Many services do not need to be provided, especially if we're talking about low threshold services, do not need to be provided in tertiary hospitals, or they could be provided in primary care, but we know that in the majority of countries there are serious limitations in terms of human resources. And so good quality partnerships with good supervision and good collaboration between both sectors could, I strongly believe, lead to a much better mental health response.
One of the tools that I think is key is peer support. So where I work in London at Chelsea Westminster Hospital, we are implementing peer support in our outpatient settings. Peer support has demonstrated to decrease anxiety and depression, to increase the knowledge and the well-being of people living with HIV, that by understanding HIV, they can take better care of themselves. They can themselves contribute to the improvement of their quality of life, their health. They can improve their mental health, and also they can, it supports retention into care. And that, again, we go back to how important it is to maintain an undetectable viral load while being well and all equals you. So you can see it's a circle about solutions to overcome fear, stigma, mental health concerns, and implementation of peer support. I think it's definitely one of those solutions.
On the positive side, I could say that I recently had a consultation with a surgeon. So I had to undergo a surgery, and I told him I had HIV, and all he asked me was, are you on treatment? Are you undetectable? And how long have you been, undetectable? And that was it. So sometimes, we anticipate, rightfully or wrongfully, we anticipate stigma that may be coming from healthcare professionals. But this makes us understand also the fact that this person was probably knowledgeable about, modes of transmission, about what HIV treatment is, and so on. So there is a direct connection between knowledge and enacted stigma.
We have in pretty much all the projects that we implement, we have people from the communities that the projects are supposed to work with who are part of the project teams, so peers. And the fact that they exist and they are a part of the project teams makes an enormous difference, again, because there's familiarity. You have someone there in front of you that tells you, I've been there. That happened to me. This is how I coped. This is what I could do. And I can help you depending on what you need, on what you want, but you can do the path with someone else instead of doing that path alone. Creating safe spaces and safe environments is paramount when the majority of your life was spent being mistreated by a series of other people in a series of different environments. We have people that only go to the hospital because someone goes with them, because otherwise they would not go because they've been mistreated so many times that they don't want to go back. We need to have people working in our institutions that are well trained and that cannot, under any circumstance, treat people differently because they dress like X or they behave like Y or they look like whatever.
Peer education and peer support have proven to be beneficial in helping people living with HIV in coping with their self-stigma and with their psychological distress. This has been also my case because in the past, I have benefited from, in the early days, from this mutual support we had one with the other, and which gave me, it gave me the courage to move forward, to move on, and this helped me a lot in coping with my self-stigma as well.
I think it's very important to educate healthcare professionals within the HIV field, but also beyond the HIV field.
So there's a lot of evidence suggesting that HIV stigma is still present within the healthcare settings. So educational trainings, for example, to healthcare workers, of course, would be beneficial in, let's say, lowering the level of stigma. A recent Italian study has highlighted how healthcare workers still connect HIV to certain populations. I think what we have to do is monitor episodes of stigma and discrimination within the healthcare settings and try to, signal them and to avoid that these can happen in the future.
You know, it's easy to say training and teaching and education, but how can we actually make sure it's implementing outside the HIV community? So I think we need to go to our hospitals, to our trusts, knock at the door of the person in charge of education and say, can you please make sure that everybody that has a contract with this hospital understands HIV, well-being, and U equals U. I call it mandatory training because it is mandatory until stigma in the healthcare institution is gone. When stigma is overcome by understanding U equals U, living with HIV and well-being, we don't need it anymore. We don't need to call it mandatory. This is why, although I understand the term mandatory might not be very nice, I think we still need to use it. We need to use it because we have a gap to fill. We have a concern to address, which is stigma in the healthcare institutions.
And not doing so is costing us a lot. It's costing us a lot in terms of effective clinical outcomes for a lot of people with different illnesses, HIV, hepatitis, TB, etc., because people stop coming because they don't want to go there. And it's costing us a lot in terms of morbidity at the level of mental health. Because then people with these cycles of stigma and discrimination, people's mental health will deteriorate over time.
And sometimes also your perception of self-stigma is very difficult to, let's say, understand. for the work I was doing, every day I would, just go around different places of work, and we would have coffee at the bar, like in Italy, have an espresso, and sometimes, you divide it, one espresso, two people, because, you cannot take 10 espressos a day. So one day I was doing this with a friend of mine, and I realized what was happening is that I was always telling the person to take the coffee first. So at a certain point, there was this friend of mine who was close to me, and he said to me, "No, Mario, it's you that have to take it first." I said, "Why?" "It's you that have to take it first." So at the end, I realized that it was myself, who was, self-stigmatizing myself of, let's say, with the fear of transmitting HIV in some way, which was actually not possible, which I also understood, which was not possible.
People don't proactively look for help when they're not well. Oftentimes people don't even know where to look for help. And sometimes even when they look for help, there's nothing that can respond. So we need services, yes, but we also need people to better understand what mental health means, why it's important, and what they can do to take care of their own mental health.
We see some key documents that actually contain areas where quality of life, well-being, U equals U, mental health concerns are very well described and discussed. There is a session on quality of life and well-being in the EACS guidelines, for example. A key document for me is the BIVA standards, because the BIVA standards have been written by people living with HIV that discuss peer support, mental health, well-being, that underline the importance of people living with HIV taking on the responsibility of looking after themselves, but healthcare professionals should contribute to that. So that is all very important, because it does add to the training and education that we are discussing to address stigma associated to HIV.
So what continues to work well is peer support and peer education, which helps people in coping with their self-stigma, in linking them to healthcare services, and then also in, let's say, making them have a more proactive attitude towards their healthcare.
There are clinics who provide an integrated approach where you have access to professionals from both infectious disease area and mental health, where you are followed by a multidisciplinary team that you can contact that respond to your needs. So they exist, but they are few. So we have good models. One of the things that is missing is scaling up those good models that have already given proof that they work. So we also know that people living with HIV, generally speaking, have a bigger burden of mental health issues than people not living with HIV from the research that is published so far, which means that there is a big need to provide integrated care between HIV and mental health.
We need to work as multidisciplinary team. We have this team at Chelsea Westminster in London, where I work. We discuss people that need further support by putting together doctors, nurses, psychiatrists, psychologists, health advisors, peer supporters, very important. We do involve peer support in the majority of clinical activities and decisions we make about the health of people living with HIV that attend our clinics. The experience and the opinion of everybody really helps to address the needs of people that attend clinics and have mental health concerns. We do see high rates of anxiety and depression. We're very lucky because where I work, we have an HIV psychology service dedicated to our outpatient settings, and so we can refer people to them.
So what is missing is a formal acknowledgement from our decision makers of the importance of a synergy between clinical centers and the community-based organizations. except for a few good practices across Europe. Most of this is left to the goodwill of the individual, let's say, healthcare provider, who in time may have a good collaboration with local NGOs. But this is the situation today.
What is missing is good linkage between different types of services. Not all infectious disease units will have the possibility to have an integrated mental health service, but all of them have the possibility to create a network of referral where they can refer people who need mental health support. We're missing good models of low threshold services outside clinical settings to make sure that people have easy to access services that they can go to, that they don't require bureaucracy, that they can just show up and they have some level of support. To get better collaboration, we need people to be aware that this should be a priority, and it's still not a priority. Mental health within the field of HIV is starting to be discussed more seriously over the last few years, but it is not still a priority, and it should be.
I am aware that working in London is a privilege because over the past few years we've been seeing a remarkable decrease of new diagnoses because of all the tools that we have available that we can implement in our clinical practice. Treatment as prevention, testing in emergency departments, pre-exposure prophylaxis, and so on. Because my message to everybody else is listen what it has been done. Join initiatives like Fast Track City that are very much on top of the pledge to get to zero new diagnoses by 2030 and are working with the UNAIDS and are very much involved in achieving the UNAIDS targets. Look at what area of the world I have done in order to stop HIV transmission, to decrease HIV-associated stigma, and try to catch up and focus on well-being of people living with HIV.